Welcome to the Cervical Spine Patient Pre-Op Education class. My name is Sarah Hewitt, a nurse and your care coordinator. I will be joined later by Dee Dee Decker, one of our occupational therapists. Patient and visitor information. We do ask that any visitors coming to see you are cold or flu-like symptom free. Our main entrance doors open at 5 a.m. and they close at 8 p.m. When you are here for surgery, the main entrance doors will be open. If you have anybody coming in before 5 a.m. or leaving after 8 p.m., they will have to enter and exit through the ER. You are allowed to have 2 visitors here at the hospital during your surgery, and one of them can be back in the same day surgery area with you until you go back for surgery. Once you get admitted to the hospital, if you are spending the night, you can have as many visitors as you want to come and visit you. You are allowed to have one coach spend the night with you if you desire, and we do ask that your coach wear their coach button. And this is the coach button, and just in case your coach is here in the middle of the night, we don't allow all patients to have visitors, and then also gives us reference that we're okay to talk to them after your surgery. Some class objectives. I want to make sure that you understand your procedure, what to expect during your hospital stay, the role of your coach. We'll talk about pain management, what physical and occupational therapy we'll be doing while you're here at the hospital, the expectations we have for you at home, the discharge planning, and the big purpose of this class is to ease your anxiety and answer any questions that you may have. The role of your care coordinator, myself, is to help teach the pre-op education class. I do daily rounds, so I'll be coming in and checking on you Monday through Friday. I'm your advocate, so I want to make sure that you're having a good experience. Each morning we will meet with your nurse and case manager, so if there's anything needed prior to you being discharged, we'll have that all set and ready for you before discharge. And you should be receiving some follow-up text messages and reminders leading up to surgery and then after your surgery. You will be up on our 4th floor. It's a dedicated unit. It's our ortho spine unit. You'll have a private room, and our staff went through training so they know how to take care of patients who are having spine surgery. We have a rehab room on the unit, and it has a tub shower combo. So if you have a tub shower combo, sometimes that can be a little tricky stepping over the tub wall. So our occupational therapists like you to have a shower bench, and the shower bench allows you to sit on the outside of the tub, swing your legs over, scoot in, and then stand up. You also have that bench so you can sit down if you don't have that endurance for your entire shower. We do have a practice set of stairs with 4 steps that we will practice with you prior to discharge if you have any stairs at home. A little bit of your spine anatomy. Your spine is made up of 33 vertebrae. 24 of them are separated by the spongy disc. That a lot of times is the culprit of your neck pain, and so that's the part we're going to remove. So I'm going to show you that. So this is the cervical spine. You have your little vertebrae here, and then the spongy discs are in the middle. So that's the part that a lot of times will go bad. This is the front of your neck. On the back side, you have something right here called the spinous process. This is the bone you feel when you're going down someone's spine. And on each side of the spinous process is called a lamina. Down the center, you've got your spinal cord, and then you have your nerve roots. At each level, you have these little nerve roots branching out of each level, and then you've got some blood vessels running alongside those as well. And so this is the cervical spine and some of the landmark pieces. Indications for spine surgery, one of them being degenerative disc disease. This is actually normal body wear and tear on your spine. Those discs start to dehydrate, they shrink in size, and they can start collapsing and start putting pressure on those nerves, causing some neck pain and arm pain. This can lead to arthritis, disc herniation, or spinal stenosis. In this picture you see on the screen, on the left-hand side, that is what your cervical spine should look like. You see the vertebrae, you see the cervical disc, you see the white on the outside of the spinal cord, and so all that is normal. If you look to the picture on the right-hand side, you can see that herniated disc, and it's pushing into that spinal cord, and that's where it's causing some problems and probably pushing on some nerves as well. Spinal stenosis is a narrowing of that spinal canal. This can cause pain, numbness, tingling, burning, weakness, and loss of muscle control. It can also cause you the inability to walk more than just short distances. So if you parked far out in the parking lot, you may have to stop halfway to your destination, let everything ease up before you can walk the rest of the way. This picture on the screen is a picture of spinal stenosis, very similar to the picture you saw on the disc herniation. That spinal canal is just much smaller and it's causing pressure on that spinal cord and nerves. Radiculopathy is a fancy word for compression of the nerve or nerves. This comes with pain, numbness, tingling, weakness along the course of the nerve. Myelopathy is functional disturbances of the spinal cord rather than the nerves. So it's not always accompanied by pain, but a lot of times you do have pain because there's usually some nerve involvement, but this can cause some tingling, weakness, bowel and bladder problems, so incontinence, lack of fine motor control or dexterity, so you could have some trouble writing your name, you could have headaches, and these electric shocks. When that spinal cord is getting pinched, you might get these electric shocks down your arms or your legs. Spondylosis, arthritis of the spine. This typically happens in the facet joint. So the facet joints are on the back of your neck, and it's where each vertebrae meets the one below it. Just like with a knee or something with cartilage, over time that cartilage wears off and those facet joints can start getting roughed up and causing some bone spurs. This can cause some abnormal motions in the neck, so you may feel some grinding and or crunching or some abnormal movement where you can't move your neck as well if this happens. Spondylolisthesis, this is where the vertebrae slides forward over the bone below it. It is pretty common in the lumbar spine. I still wanted you to see it so you could kind of see what that is because it can happen in the cervical spine as well. It can be something that is slowly progressing or something that happens very quickly. And this can cause, it could cause back pain, neck pain, numbness, tingling, and weakness down the arms or the legs. You have some goals for surgery. We want to remove the pressure off your nerves, move the pressure off the spinal cord, ultimately lessen your pain and get you back doing the things you enjoy. So in order to do that, we may need to do a laminectomy. And what a laminectomy is we remove the lamina. This is done from the back of the neck, and we can remove the entire lamina or just part of the lamina. And what that will do is it will open up the canal for your spinal cord. Some people get worried when that bone is no longer there, but not to worry, you've got lots of ligaments and muscles protecting your spinal cord. This procedure a lot of time is done in conjunction with a cervical fusion, but it may not. It could be a standalone procedure depending on what is going on. We can also do a foraminotomy, and I call this kind of the rotor-rooter procedure. This is where we shave around the foramen, the nerve root, to give it more room and space to move. Facetectomy, this is where the two vertebrae meet, and that's where that bone can start to get rough and form some bone spurs or arthritis, and we'll shave that area down. And if we're doing it a standalone without doing a fusion, you should have more mobility in your neck. But if we are doing it with a fusion, the goal for that is to shave those bone spurs off, get the pressure off those nerves and or spinal cord, and then we will fuse that section together. Cervical discectomy, this is where we remove the entire cervical disc, and we do that from the front of the neck. Cervical laminoplasty, this is going to hinge that lamina open. So if your surgeon doesn't want to remove the entire lamina, he could do something called a laminoplasty, and it almost makes a hinge of that lamina to open up that spinal canal to give it some more space. Without removing that lamina, it helps preserve some spinal stability. Cervical disc replacement, this is designed to replace that bad disc and allow for you to still have normal function of your neck. Not all patients qualify or are candidates for this type of procedure. Normally, you're 55 years or younger, you have minimal effects of osteoporosis, and this surgery, the incision will be on the front of your neck. And in the pictures, you can see kind of what that disc will look like. We do a couple different types of cervical fusions. We do an anterior cervical discectomy and fusion, or we can do a posterior cervical fusion. What is a spinal fusion? A fusion is fusing two or more bones together to become a solid piece of bone. We take that entire disc out and we replace it with a cage, or you may have heard the word spacer. So cage, spacer, talking about the same thing. We use bone graft material with a cervical fusion. It is usually synthetic bone when we are doing from the front, and when we're doing a posterior cervical fusion, we are normally going to also do another procedure called a posterior lateral arthrodesis, where we'll lay some bone graft material back there, and that could actually be your own bone, but if not, it'll be synthetic bone and some cadaver bone. The hardware that you will have in is usually made of titanium. Depending on what we're doing, you could have rods, plates, or screws. Most cages are made of titanium, and just so you know, if you do need to have an MRI in the future, this hardware is safe for MRIs. Robotic navigation. If your surgeon decides to use this, we will do a CT scan prior to your surgery, and what this robot does is it allows the surgeon to place those screws precisely. You'll have smaller incisions and reduction in radiation. Anterior cervical fusion, also known as ACDF, this is where we fuse two or more vertebrae together, and we use a cage and a plate and screws to keep everything together. This is the model of the cervical fusion. So this particular model is a two-level fusion, meaning two of the disc space are being removed, and then we will put the plate and screws on the front. Also, if you are a heavy smoker, your surgeon may opt to not do a cage. They may use part of your iliac bone, because sometimes if you're a heavy smoker, that bone won't ever fuse, it will never grow, so they opt to do a piece of the iliac bone. Posterior cervical fusion, just as with the anterior cervical fusion, the ACDF, we're going to be fusing two or more vertebrae together, but with this one, we go posterior. We're going to go on the back side of your cervical spine, and we were going to use screws and rods to keep everything in place. We do not do any access to the disc space with this procedure. This procedure is only applying the screws and the rods on the back of your cervical spine. With the posterior cervical fusion, a lot of times we will do the posterior lateral arthrodesis, and that is where we lay bone graft material on the back side of your spine. As you can see in the picture, it's just laying those bone pieces, and those two vertebrae will then fuse from the outside, giving them more stability. This is often used with cadaver bone, your own bone, and synthetic bone. This is a picture of an anterior and posterior cervical fusion. If you can see in the blue bracket, C5 to C6, that's a previous cervical fusion. That looks like one big fat bone. That's actually two vertebrae that have successfully fused together. But if you look above to C3 to C5, you can see that there's still some black space in between those vertebrae, and so that is a fairly new cervical fusion. So that's an anterior, but it's also posterior, so you can also see the screws and the rods on the back side. So that person had both anterior and posterior cervical fusion, C3 to C5. There are some risk factors with surgery, with any kind of surgery, but these are the ones related to spine surgery. Spinal cord and nerve injury. So your surgeon is working close by those nerves, by the spinal cord, so there's always that tiny chance they could nick the spinal cord or nerves, but they do have some safety nets to help with that. They will put these neuro monitoring wires on, and before your surgery, they'll get hooked up to your wrist and down on your ankle. So during the procedure, they have full visualization of those nerves. Now also, in addition to these little sticky wires, you may have these little drops of blood on your head, on your bruising on your wrist or your legs, and that's from these little tiny baby needles that we will apply when you're asleep. But just know you may notice some of that when you wake up, and that's from those little tiny baby needles during the neuromonitoring. Vascular injury, you do have some blood vessels that are running alongside your spinal canal, so there's always that tiny risk of a vascular injury. Non-union. So our goal with your surgery is to fuse these vertebrae together. So sometimes what happens is they don't fuse correctly. There are some risk factors that can contribute to that. Number one thing is smoking. Smoking constricts blood vessels so that oxygen-rich blood is not getting to that spine, and nicotine softens bone. So we're trying to grow bone, and so if you're softening it with the nicotine, that does not mix very well. Some insurance companies will actually want you smoke-free prior to your surgery, maybe even a month prior. Our goal for you is to be smoke-free at least 1 week to 6 weeks after. We would like for you to be smoke-free. Longer the better though. Also, if you have any obesity, that just puts extra stress on your body. Osteoporosis, that is where your bone isn't as dense, and so it may take longer for that bone to grow. Diabetes is an overload of sugar in your body that can slow down the healing, and malnutrition. So make sure you are eating a well-balanced diet. Lots of protein and lots of vegetables are good for wound healing. If your surgeon is concerned about the bone growing, they could order something called a bone stimulator, and that will be delivered to your house after your surgery. It kind of looks like a TENS unit. So if you've ever used a TENS unit or seen a TENS unit before, it has little sticky pads, and the pads will be placed on either side of your cervical spine, and it will send these messages to the bone to tell it to grow faster. Adjacent segment collapse. So this is the part where your friends may have told you, oh no, you're having spine surgery. Once you have one, you're gonna have one after the other, after the other. So to an extent, they're not lying to you, but they're also not 100% correct, because everybody's having spine surgery for different reasons. You could have a degeneration of those discs just over time. That's just your body wearing and tearing, or you could have had a car accident or a fall, and so just that one section has been damaged and needed surgery. So why they say that as well is because when we start fusing vertebrae together, instead of each individual one moving on their own, now you've got two vertebrae acting as one. So over time, wear and tear the disc above it, the disc below it can start taking on that extra strain and cause those other areas to go bad. A lot of times your surgeon can review your MRI and kind of give you an idea of what the health of those other discs are. Also, dural tear. When we're doing an anterior cervical fusion, the risk of a dural tear is much, much smaller. But when we're going on the back side, when we do the posterior fusion or a laminectomy, where that lamina is, bone spurs can form underneath here and are wearing and tearing at that dura. So when your surgeon goes to remove that bone, it's like tissue paper and it tears. So what happens is they'll repair it, they'll either suture it up or put a patch over it, and then they will put you on bed rest, meaning they are gonna have you lay flat. The reason why we have you lay flat is it'll take the pressure off that spinal cord and allow that space to heal. You are allowed to turn side to side. We just don't want you sitting up because that's putting pressure on the dural tear. So we'll have you lay flat. Usually it is an overnight bed rest depending on the size of the tear. Infection, we don't plan on you having infection, but we do want you to know what to look for. So if you start running a fever, having increased pain, swelling, redness, heat, any abnormal drainage like any green, yellow, cloudy, smelly drainage, or if you're having drainage lasting over a week, you definitely want to let your surgeon know. Be sure to wash your hands before touching your incision. We prefer your pets not to sleep in the bed with you. We don't want your pets licking your incision. If you don't have the heart to kick your pets out of the bed, give them their own covers to the foot of the bed, and you may want to wash your sheets more frequently. We do want you to wash your sheets at least once a week, because us as humans are also covered with bacteria and we're constantly shedding our skin cells. So at least once a week, put fresh bed sheets on your bed. CHG bathing. This is going to help prevent infection. It's going to kill that bacteria off your skin. During the hospital stay, we will be using some CHG wipes, and you will learn about the CHG wipes before your surgery later on in the presentation. But these are the CHG wipes. There are 6 wipes in here, and further on the presentation, we will show you how to use them, but you'll be using the wipes during your hospital stay, and when you go home, you will be using the CHG solution and the sponge. So how you use this is when you're in the shower, you're going to suds up really good. You will avoid your face, your hair, your private areas. Make sure you're not getting it in your eyes. You'll suds up, you'll let it sit on your skin for 2 minutes, and then you'll rinse it off. Be sure you're not directly scrubbing over your incision, but scrub around it and allow the soapy water to run over it. Make sure you're drying off with a freshly washed towel. Don't be putting any lotions, perfumes, anything like that on the skin, because that'll deactivate the CHG from working. Bathing and incision care. So like we were saying, you are allowed to shower. You can get the incision wet once the initial dressing comes off. The surgical dressing is usually removed 2 to 5 days after your surgery. We will talk to you about that after your surgery is over with, so you'll know exactly when to take that dressing off. Once your surgical dressing is removed, you can start doing daily dressing changes, get the incision wet. You will put a fresh dressing on every day until there's no more drainage. You want to look at the bandage, the dressing for the drainage. Don't look at the incision. So once that dressing comes off clean, like you put it on the night before, then you are good to keep it off and leave it open to air. We do not want you to put any ointments or peroxide on that incision. If you are concerned for infection, you are calling your surgeon right away. Only showers, no tub baths, no swimming, no hot tubs, no submerging underwater until your incision is completely healed. And again, once you're done, so you'll use the CHG wash for 7 days post-operatively, and then after that, you'll go to your normal soap and water. Your incision will be sealed with Steri-Strips and or Dermabond, which is a purple glue. Sometimes the surgeon will use something called a Dermabond Preno. And what that is, it's like a Steri-Strip, but more of like a mesh, kind of like a window screen, and they'll paint the Dermabond over top of it, and it gives it that extra stability, a little bit stronger. With the Dermabond and the Steri-Strips, we do not want you to remove those. Those will all naturally fall off on their own. Sometimes your surgeons will use sutures or staples depending on where the incision is, and those would need to be removed at one of your follow-up appointments. Sometimes they will use a small vacuum device to help with wound closure and help it heal a little bit faster. If you do have one of those, we'll talk in more detail after your surgery. Average length of time for surgery, and this could vary depending on how many levels are being operated on, but for a cervical disc replacement, 45 minutes, and ACDF is about an hour to an hour and a half. Posterior cervical fusion is 1.5 to 2.5 hours. A cervical laminoplasty is 1.5 hours. And if they were to use any sort of robotic with it, then that would add a little extra time. Now this time is just the time that your surgeon is in there doing the procedure. So add another 45 minutes to this time, and that's how long you'll be in the operating room. The length of stay for your surgery for our ACDF and cervical disc replacements, those can both be outpatient or usually just a one-night stay. Cervical laminoplasty is 1 to 2 nights, and a posterior cervical fusion 1 to 3 nights. The healing times for our cervical disc replacement is really, you want to be cautious for the first 6 weeks. Same thing with the laminectomy. Just be cautious for the first 6 weeks. You don't want to overdo it. With the cervical fusion, however, you want to be careful for about 3 to 6 months. It takes about that much time for that bone to start really growing strong. Now it can take up to a complete year for that bone to completely fuse and fill that entire disc space. Returning back to work, this can vary greatly on what you do for work and what type of procedure you have. But for light duty is about 2 to 4 weeks. Heavy duty is 3 to 4 months. Make sure you are getting cleared by your surgeon before you are returning back to work, and before driving as well. We don't want you driving until you get the A-OK from your surgeon. Rule of thumb for driving is you are off your pain medicine during the day, good hand strength, good feet strength, feel safe to drive, and yes, ultimately get permission from your surgeon. I know we have gone over a lot of information, so this is a great time if you want to pause the video and take a break. The next section, Dee Dee will be going over preparing for surgery and what to expect after surgery.
Welcome back. My name is Dee Dee and I am the lead occupational therapist here at Stonecrest. We're now going to talk about how to prepare for your cervical surgery. The guidebook is wonderful. It is filled with tidbits, facts, and so much information that we've also discussed in this presentation. If you have any questions, you can always reference your guidebook. We also encourage you to bring your guidebook with you to any surgeon appointment as well as your surgery. We also ask that you prepare your home for this surgery. So make sure you put away anything that could be a tripping hazard and get yourself a supportive chair with armrests to make it easy to stand up and sit back down as your recovery. Shop ahead, have some easy to prepare meals, and make sure you have somebody else cooking them for you. Try to have somebody there with you for the first week to help care for you as you recover. Speaking of that person, we like to call them your coach. Your coach is somebody we love here at Stonecrest because first off, they know your baseline. They know what you are like before pain medication and before anesthesia. So if something were to go wrong, they are probably going to notice before we will. Also, they don't have medication or anesthesia in their body, so they are going to help keep you accountable once you go home, because you might have a hard time remembering what we are telling you here at Stonecrest. Some things to note for your coach is that our visitor cafe is only open for breakfast and lunch. However, they are able to order dinner alongside you, the patient, from one of our dietary staff members. It will just be brought up to your room with your meal. The newsletters, daily homework, and coach's checklist are items that Sarah or your nurse will review with you during your stay here after your surgery. Our incentive pathway is a poster that's in all of our orthopedic rooms. It is our road to recovery, filled with checklists that you will meet in order to discharge home. We ask that you stop any medication that increases bleeding 7 days before your procedure. If you are on any sort of medication such as Coumadin, Plavix, Xarelto that is prescribed by a doctor, we ask that you speak to a prescribing doctor before stopping this medication. Tylenol is okay to take before surgery, but we just ask that you please tell your same-day surgery nurse that you have taken Tylenol that morning. Pre-admission testing is our hospital's way of preparing for your surgery. When you come in, you will check in at our registration desk and they will guide you back to your pre-admission testing appointment. From there, you will meet with a hospitalist who will review your medications that you are taking as well as your past medical history. You also might have some lab work done and a few other procedures. You could also meet with an anesthesiologist. If this is not the case, don't worry. We will talk a little bit about anesthesia in this presentation, and you will be able to meet with that anesthesiologist on the day of your surgery. Please note you need to stop taking your GLP-1 drugs 8 days prior to surgery. These include Ozempic, Wegovy, or Mounjaro. During your pre-admission testing appointment, we will also test you for MSSA and MRSA. These are antibiotic-resistant bacteria that can live dormant in your body, but can cause a very large infection if they awaken. If you do test positive for this bacteria, you will get an ointment sent to your pharmacy as a prescription that we ask you to take for 5 days leading up to your procedure. What you will do is put 2 little dabs in each nostril each day, twice a day. Please bring that used tube of ointment with you to your surgery so we know that you've taken it. Other things that you can bring with you. This is a very long list, but I want to hit the highlights. Don't forget your insurance card or your ID. Also, if you have sleep apnea, please don't forget your CPAP or BiPAP machine. We ask that you bring comfortable, loose-fitting clothes to change into following your surgery, as well as slip-on shoes. We love shoes that have a back and ask that you do not wear Crocs or flip-flops as they can be fall hazards. Also, please, please, please protect your body from cuts, scrapes, scratches, all of the above, as this is something that can postpone your surgery. We ask that you take 2 extra strength Tylenols, which equals 1,000 milligrams, 3 times a day for 4 days leading up to your surgery. If you are taking any sort of pain medication that has acetaminophen in it, we ask that you do not take this extra Tylenol. We encourage good nutrition leading up to your surgery, so please reduce your sugar intake and eat lots of healthy, lean green vegetables as well as protein. ESR stands for Enhanced Surgical Recovery. It is the model we use for all surgeries here at Stonecrest, whether you're having a back, joint, or belly done. This is the model that we follow. There are lots of benefits to using ESR, but our biggest benefit is increased patient satisfaction and increased patient outcomes. The night before surgery, we want you to shower as normal and dry off with a clean towel. You will then wipe off with CHG wipes that are provided to you during pre-admission testing. We ask that you wait 1 hour following your shower to use these wipes, as they are very, very harsh, and we want to make sure your skin is dry. Please go to sleep with clean sheets that night and do not shave your legs or neck before surgery. This is our model of how we want you to wipe off your body using that entire pack of wipes when you use them. Now, we ask that you don't eat anything after 11 p.m. the night before your surgery. However, you can drink clear liquids up until 2 hours prior to your arrival. At that point, we would like you to drink our carbohydrate-rich drink. Let me show you. This is our carbohydrate-rich drink filled with electrolytes that we would like you to drink 2 hours prior to your arrival here for surgery. If you are diabetic, you will not receive this in pre-admission testing, and instead we ask that you use something such as Powerade Zero, Gatorade Zero, or Propel. We don't want to up your sugar before surgery. If you are somebody who is using a GLP-1 drug, we ask that you don't eat anything 12 hours before your surgery. And we also ask that you don't drink anything for 12 hours before your surgery either. Please remove all jewelry and body piercings and do not wear deodorant to surgery, as it is not compatible with our CHG wipes. The day of surgery, do not shower. The CHG wipes are still working, and we want them to be as effective as possible. You'll also come in and check into the registration desk. From there, they will direct you to our outpatient waiting room. As a reminder, you can have 2 visitors wait with you in the outpatient waiting room, but only 1 can go back with you to same-day surgery. In the outpatient waiting room, you will meet with your same-day surgery nurse, and she will take you back and get you prepped for surgery. Once you are back in same-day surgery, your nurse is going to help you get ready for this surgery. This includes starting your IV and wiping off again with those CHG wipes. She's also going to give you a nasal antiseptic that clears bacteria in your nostrils for over 12 hours. From there, she'll do a head-to-toe assessment to make sure that you're clear of scratches, tears, or skin breakdown. She will start your IV, give you any pre-op medication that you need, and repeatedly ask you questions such as, what is your name, what is your date of birth, and what procedure are you having today? You'll also meet with the anesthesiologist. During your surgery, your coach is going to wait in our outpatient waiting room. There is a TV tracker in that waiting room where they will be able to follow along with your surgery. It is important to note that if you have any loved ones that would like to call and ask about your surgery, they must have a passcode that you or your coach can get on the day of your surgery. We also ask that your coach turns on Wi-Fi calling and off spam blocker, as your surgeon will call them at the end of your surgery. And we want your coach to have the best opportunity to answer that phone call. The Informer is our text message system that alerts other loved ones who are not in the building of how your surgery is progressing. It is just like our TV tracker, but in text message form. Please note that you must know your account number in order to sign up for the Informer. You can receive this at the registration desk on the day of pre-admission testing or on the day of your surgery. After surgery, you are going to go to our post-anesthesia care unit, or our recovery room. Here, they will monitor your vitals and make sure that you are waking up safely from surgery, as well as keeping your pain under control. From there, you are going to admit to our orthopedic unit. How are you going to feel after surgery? You're probably going to be tired, and that's okay. We ask that you take as many naps as you need, especially that same day that you have surgery. You're probably going to feel a little queasy after all of that medicine that's in your body. So we ask that you begin with light food. Not time for the greasy cheeseburger, guys. You also are going to feel sore, and you might have some difficulty with swallowing. So please eat soft foods, fruit smoothies, mashed potatoes, or popsicles. Avoid meats and breads, things that require a lot of chewing and swallowing. And this would be difficult for me, but please avoid talking. You will also have a urinary catheter. If it is present, it will be removed later that same day you have surgery or the next morning. Also, you could have a drain present. Let me show you a few different types of drains. This is our hemovac drain. These are what our surgeons like to use for all of our cervical fusions. If you're receiving an ACDF, it will be removed post-op day 1, which is the day after your surgery. If you're receiving a PCF, it will be removed post-op day 2. This is George. He is our lead physical therapist. And this picture just goes to show you, if somebody walks in your room with these colored scrubs, be prepared to do some work. Let's talk about physical therapy. Physical therapy is going to see you typically post-op day 0. We would like you to get out of bed within 4 hours of getting up to our orthopedic floor. If you have a late surgery, you might not be seeing them that night, but you will see them first thing the next morning. They really care about your functional mobility, such as walking, climbing and descending stairs, and making sure that your muscles are strong, especially your leg muscles. They also will teach you on how to don and doff your cervical collar. For occupational therapy, we care about your functional skills, such as dressing, bathing, and toileting. We are going to teach you how to get dressed, get in and out of bed, and on and off the toilet while maintaining all of your neck precautions. Speaking of those precautions, let's talk about the BLTs. No bending, lifting, or twisting. What we would like you to do instead is keep your neck and spine in alignment. That includes log rolling to get in and out of bed, not lifting anything over a gallon of milk or 10 pounds, and avoid sitting and standing for long periods of time. Remember, you just had a major surgery. We really want you to rest. Let's talk about a few medical devices that you might see here at Stonecrest. First, you will all be attached to an IV pump. This is how your nurses will give you a lot of different medication. You're also going to be attached to a vital sign machine and a pulse oximeter. This little gadget goes on your finger and helps measure the amount of oxygen in your blood as well as your heart rate. Something else you will see is our gait belt. This goes around your belly and allows us as therapists to safely hold you as we are starting to walk and get in and out of bed. It is a great tool that you can even use at home because it goes home with you. These are sequential compression devices, or SCDs. We use these to help encourage blood flow back into your body. This will attach to a machine at the end of your bed and alternate back and forth, squeezing your calves to encourage that blood flow. These are compression stockings. We also use these to help with DVT prevention and pulmonary embolism prevention. You will wear the knee-high stockings during your stay at the hospital and could wear them up to a week after your surgery. Finally, let's talk about our cervical braces. They have soft collars and rigid or hard collars. The collar length and soft versus hard is determined based on the level or the amount of levels of your fusion. As you can see, this is a soft collar that we use in order to keep your neck in alignment. If you have a larger neck, we are also able to put an extender on the back of your neck so that it does not feel as if it is choking you. Occupational therapists will also review assistive devices. These are imperative in helping you perform the things that you want and need to do while maintaining your back precautions. Let's go over just a few of them today. First and foremost, this is a long-handled sponge. It is exactly what you want to use when you are showering, as it allows you to reach everything from your head to your toes without bending or twisting. This is a reacher. Again, I have a lot of patients use it as they're getting dressed, donning and doffing their pants, their underwear, and it's even helpful to pick things up from the floor or something high above. This is our long-handled shoehorn, and while I love this model, there's even one on Amazon that I like even better that's longer and made of metal. It is what's going to help you get your shoes on, as we stick this in the heel of your shoe and you can guide your foot down so you're able to put your shoes on independently. Finally, this is a sock aid. This is how you are going to get your own socks on. You will put your socks on by pulling it tight where it's taut across the top. Be sure to be aware of these knots because we want to make sure you don't put the sock over them. Your sock can scrunch up as much on here as needed. You will then toss it down, slide your foot in, and pull using these ropes. You can pull, 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 and when you feel like you're done, keep on pulling and it will get your sock on. This thing is pretty great. Finally, something that is really important that I think is wonderful is a bottom buddy. It is a way that you can wipe your own bottom without worrying about twisting or bending too far. If you have any questions about the bottom buddy, please talk to your occupational therapist while you're here. Some other assistive devices that could be beneficial to you during your recovery are the following. We love a shower chair. This is something that is easy to put in your shower and you can use it your first few days when showering. A shower can take a lot out of a person, and it's much, much better to take a seat if you get tired than to try to get out of the shower, slip, and fall. You also might be given a walker. If you are having difficulty moving after your cervical fusion, a walker can be beneficial in order to help keep your balance and make sure we are not having a fall at home. Finally, if you're having difficulty getting up into the bathroom quickly or have a low toilet, a raised toilet seat or bedside commode could be beneficial to put in your bathroom during recovery. Here are a few post-op exercises that your physical therapist will go over with you in further detail. First are ankle pumps. We just ask that you pump your ankles up and down 20 to 30 times every half hour that you are awake. Do not wake up to do any of these exercises. These are great because they also encourage that blood flow, again, back into your heart and through your body. We also encourage that you do your nerve glides 5 sets of 10 throughout the day. Don't do them all at once, but we eventually want you to be able to do 50 nerve glides per leg. Something else that's very important is walking, getting up and moving, not sitting or standing for too long of a period of time. But please be aware, we don't want you walking more than 2 miles within the first 6 weeks of your recovery. Finally, let's talk about your incentive spirometer. This is a device we use for anyone who has a surgery here at Stonecrest. What you are going to do is you are going to suck in through this little tube 10 times every hour. You do not have to do this consecutively, but we do want you to get up to 10 for every hour. When you suck in, this little green guy will raise to the volume that your nurse sets. We also want to make sure that after the 10th time, you follow it with 2 good coughs. You are going to do this for 5 days after your surgery, 10 times an hour, but do not wake up to do this if you are napping. Daily homework. Sarah is going to review your daily homework while you're there, but we always want to make sure that you are sitting up in a chair and you are out of bed for your meals. Again, movement and walking is a very good thing, and we want to encourage that. Also, it might be hard to find a comfortable position sleeping if you are a stomach sleeper. We really encourage you to keep your neck in neutral. And sometimes sleeping in a recliner might be more comfortable than sleeping in your bed. Please log roll every single time you get in and out of bed. And if you are unfamiliar with the log roll, don't worry. Your physical and occupational therapists will go over it with you. Take time resuming all of your daily activities. Do not rush this process. You're recovering from a major surgery. When you are here at Stonecrest, we ask that you follow this mantra: call, don't fall. We want to make sure that you are safe anytime you are getting out of bed. So please use your call light to call a nurse instead of trying to get up on your own. You are attached to so many different wires, tubes, and machines. We would prefer that you are safe rather than sorry. This is our pain scale. Everybody who comes into your room is going to ask you on a scale of 0 to 10, what is your pain level? This is how we make sure that your pain is managed well. We use a multimodal approach here at Stonecrest to our pain management, which means that we don't just use pain medication. In fact, ice is something that we like to use, as well as movement. A few items to note about pain management. You might be attached to a PCA pump, and that means you and only you are allowed to press the button to administer your pain. You are experiencing a different type of pain after this surgery, more of a surgical pain. Remember, we want you to take your pain medicine as prescribed. We would rather you intercept the pain rather than catch up to the pain. But if your pain medication is not being effective, please tell your nurse. Also know that your pain medicine, while scheduled, is typically ordered PRN or as needed. So you must ask your nurse in order to receive pain medicine. And if you don't hear anything else in this video, hear me for this. I don't see patients come back here because they've experienced a fall or got an infection. I see a lot of patients return to the hospital because they have not taken a stool softener with their pain medication and are backed up from that. And that sounds very, very uncomfortable. So please find a stool softener that works for you and take it while you are on pain medication. Cold therapy is something we love to use here at Stonecrest as a way in order to reduce swelling and pain. You can make a homemade ice pack by combining equal parts water and alcohol into a Ziploc baggie. I always double bag it to prevent leakage and then put it in my freezer so it will form into a gel. We always ask that you put some sort of barrier between your skin and the ice pack so that you are not getting a burn from the ice. You can also apply heat to any part of your body that is hurting except your incision. We do not want to put heat near the incision area, and please limit your heat to about 15 minutes for every hour. Again, we encourage movement, repositioning, changing positions, and even walking might make the pain lower. As always, if you have to cough or sneeze, please brace with a pillow so that you aren't hurting yourself. Remember, we can't make the pain go away completely, but we do want it to be tolerable. If you have nerve pain, it could take upwards of a year for that to go away completely. So please be patient with your recovery. You will not get addicted to your pain medication once you are at home. Please make sure you are taking it as prescribed by your doctor. And do not take any other narcotic pain medication except the one that is prescribed to you by your doctor. You might also take some NSAIDs in order to help with the pain. This includes ibuprofen or Advil. Please do not take any other pain medication than the ones prescribed to you by your surgeon. When you go home, we ask that you use your primary pharmacy for all of your pain medication and other medication. However, know that some pain medication might be restricted. If you have any sort of issue with your pharmacy, please contact your surgeon. Your rolling walker, if it's required for you, will be delivered prior to going home, and make sure you have a ride ready to pick you up around lunchtime. Plan ahead for somebody to be at home with you to help care for you, as well as any pets you might have. Pets can unintentionally cause falls, so if you have a little one at home, try to put them away in a separate room until you are settled. Then slowly introduce them to you. Home health in a skilled nursing facility might be recommended by a therapist, but we know that you recover better at home. If you are recommended to go and receive home health or go to a skilled nursing facility, we will talk about that during your stay here. Your follow-up appointment is typically scheduled in 2 to 3 weeks, and if you are a workers' comp patient, please be in contact with your caseworker prior to surgery. Pick one day each week to measure your progress. This is a major surgery. You are going to have good days and bad days, and it can get pretty discouraging comparing one day to the next. If you pick one day each week to measure your progress over that past week, you will feel much more encouraged. If you feel like you are being discharged too early or a decision is being made about you without your consent, please come talk to us. This is your surgery and we want it to be as successful as possible. We also want to invite you to our reunion luncheon. It is held once a quarter and it is held in our medical office building. It is provided by our staff here at Stonecrest, and it's a wonderful time of fellowship as well as letting team members see your progress. If you come in contact with a wonderful staff member, you are always able to nominate them for the following awards. If you have an exceptional nurse, you can nominate them for the Daisy Award. The Rose Award is for other staff members such as therapists, EVS workers, or dietary staff members. And you can always nominate your surgeon for the Mid-Level or Physician Award. My Health One is our online patient portal. It is where we manage all of the information regarding this hospital, including information about your hospital stay, your surgery, and your hospital bills. You can create a login at myhealthone.com or tristar-stonecrest.com. If you do take photography or videos during your stay here at Stonecrest, we ask that you receive verbal consent from anybody else in those videos prior to taking them. Our Care Pathway Survey is our PROMS survey, or our PROMS survey. This PROMS survey is what we use to justify doing more back surgeries here at Stonecrest. It is how we measure your progress throughout the year following your surgery. Please fill out the survey that you have already received if you haven't. And please expect another one at 6 weeks, 6 months, and 1 year following your surgery. We're also going to send you a Press Ganey survey. This is our patient satisfaction survey. If you had a wonderful experience here at Stonecrest, please tell us about it. We want to know. But if you didn't have a wonderful experience at Stonecrest, please tell us about it. We don't know what we can change unless you tell us. You can also review us on Google, Facebook, or Yelp. And thank you for attending spine class. I appreciate the time that you have spent with me here today. If you have any further questions, please contact Sarah at the number on your screen. She is available from 8 a.m. to 4 p.m. Monday through Friday. Thank you.